That was way too much. Thanks, Ann. You've always been over the top on this, and I appreciate it. I just need to get my slides up here. Excuse me for 1 minute here.
It's dessert.
Thank you. The electronics are always the issue, unfortunately, so we'll see if we can get this to work right. One of the things I was concerned about in talking to all of you today, and unfortunately I can't see the slides so well, I don't want to get away from the microphone too much because I want to make sure everyone can hear me. This is all about you guys, and these pictures, frankly, I stole from a CF Foundation presentation, and one of the things the CF Foundation says is to steal shamelessly. If someone else has a good idea, use it, and that's a good thing for us. If some center is doing something that helps our patients, we should steal it and use it. That's okay. So I did steal some slides, and you'll see a bunch of them. The other thing I'm a little bit intimidated by is the audience here. You guys, I'm used to boring medical students. It's a little tougher with an adult audience with lots of different ideas. But Mary Ellen said I had an hour to speak. That's a long time. I really don't want to put you all to sleep with it. But I'm going to talk a little bit of history of CF just because I think it's kind of interesting. And I think those of you who are parents or grandparents or those online who have CF, it's fun to kind of know what happened and how we got here to begin with. I'll do a little bit of basic science and hopefully not put too many of you to sleep too much. And then I want to talk about the new drugs. That's what you really all want to know about anyways. Where are we now? What's going on? Where are we going to be in 5 years or 10 years? When certainly my hope is by the time I retire that this is going to be an eminently treatable disease. But we aren't there yet. We are not there yet. So, to go on, this is, okay, good. I just want to check that it really was projecting well. This is the woman who first described cystic fibrosis. Now, cystic fibrosis is a genetic disease that's been around for thousands of years, but for most of that time it was unrecognized, just that unfortunately young children passed away for reasons their parents didn't understand. In 1938, Dorothy Anderson, who's quite an imposing figure here, I would say, she described what she called cystic fibrosis of the pancreas. And Dorothy Anderson's an interesting woman. She went to Mount Holyoke College and wanted to go to medical school. In the early 1900s, women didn't go to medical school. But she got in, and I think she was one or two in her class in medical school. It was really, again, she's an indomitable woman. And she wanted to be a surgeon, but if it was hard for a woman to go to medical school, it was impossible for a woman to be a surgeon at that time. It was a clearly male-dominated field. So she went into pathology instead. She became a pathologist at Baby's Hospital in New York City. And smart people do good things no matter how much we men try to keep them from doing them. Smart women win. She noticed while she was doing autopsies on babies who had died of malnutrition that a bunch of these children had very different pathology from all the others. They had these pancreases that weren't working, that were full of scars, that's fibrosis, and holes, that's cysts. And so she called this cystic fibrosis of the pancreas. And that's where the name comes from, because Dr. Anderson saw those scars and those holes. And kind of as an aside, because she, again, smart woman who was looking at everything, she said, not only does their pancreas not work and they're dying of malnutrition because they can't absorb food, they've got infection in their lungs, and they've got some mucus in their lungs. And these are babies, 3 months, 6 months, 9 months of age, who already had lung disease. So she was able to recognize very early on what this disease was all about. And to be honest, not a whole lot further. And when we look at some of the studies that go on now in babies, it's to find out that, yes, they've got lung disease early in life. But Dr. Anderson knew that 80 years ago. What she and some of her clinical co-workers were able to determine was that they could give pancreatic enzymes exogenously to people, but they weren't very good, frankly. They're not as good as the stuff you guys have today, but they were something. And so kids did better, but still had a lot of nutritional problems and lung problems. So we're going to jump ahead a little bit to 1953, and this is Dr. Paul de Saint-Agnes. He was also in New York City. And what he recognized was in 1948 there was a heat wave throughout New York City, and a bunch of children got admitted to the hospital because of dehydration, and a lot of them were kids with cystic fibrosis. Now, CF is a pretty rare disease, and to have most of the kids coming in with dehydration have CF made bells go off in his head. What's different about these children with CF that they're the ones who are getting dehydrated? And so he spent the next several years researching this and found out that there was abnormal salt in the sweat of children with cystic fibrosis. And I'm going to guess this kind of sets off bells in your heads because you know the sweat test is the test that we use to really determine if someone has cystic fibrosis. This came from Dr. Saint-Agnes, looking and seeing. And I think that's kind of the theme here, is that people, smart people who are observing things and make connections. So he really came up with a way to do the sweat test, which is still used today. Now, he did it in a rather rudimentary fashion, but he did show that people with cystic fibrosis had abnormal sweat. But no one knew why and what was going on. So we're going to jump forward again, and this is Paul Quinton. This is a relatively recent picture of Paul, and you guys should all know about Dr. Quinton for two reasons. One is in 1983, he made a big discovery, and it was his annus mirabilis, his year of great publication. In 1983, he had two publications, one in Nature, which is the leading science journal in the world, and the other in the New England Journal of Medicine, which is the leading medical journal in the world. So not a bad year for Dr. Quinton. And he was able to describe that it wasn't, table salt, remember, is sodium and chloride. He was able to determine it was chloride, that part of salt getting in and out of cells, that was the problem. And again, big step forward for CF. Now we're beginning to understand what's going on and why it's going on. The other reason you need to know about Dr. Quinton is that he has cystic fibrosis. He's 72 years old, and he has cystic fibrosis. And he makes no secret about it. I'm not giving away any personal health information here. He has a mild mutation, obviously, but he's been working on it. Some of the sweat glands he looked at were, in fact, out of his own arm. He was studying sweat glands, and he said, oh, I've got CF, let me look at some of mine. And he was able to determine what's going on in chloride channels. And Annie was way too kind to me, but Paul is a real advocate for CF and for adults with cystic fibrosis. There's a lot of stuff going on now that wasn't an issue 40, 50 years ago because, unfortunately, we didn't have as many adult patients then. And Paul has been a real advocate for CF research, but also for CF care, because obviously he's very attuned to CF care and what's involved with CF care. He's also a good example of taking care of yourself matters, because he really has been incredibly good about using all of his medications and all the medications that come out to help him feel better. And he's on some of the newer medications that are now available. So a lesson to children and patients watching, that if you take your medicines, it makes a difference. Then the big, big breakthrough in 1989, finding the CF gene. And this picture, I'm not sure how well it shows, but Francis Collins, Lap-Chi Choi, and John Reardon. Dr. Collins, who's now head of the NIH and was head of the Human Genome Project after this, but in 1989 he was at the University of Michigan, and he collaborated with two doctors at Toronto's Hospital for Sick Children, Dr. Choi and Dr. Reardon, and the three of them discovered the CF gene, and that was huge. So for a while, we knew it was a disease that affected the lungs and the pancreas. That's Dr. Anderson. Then we figured out it was salt problems, and that was Dr. de Saint-Agnes. Then we figured out it was chloride problems, and that was Dr. Quinton. And now these three figured out exactly what the basic problem was. So from time immemorial up until 1989, we treated symptoms of CF, malnutrition, infection, but we didn't know why those things happened. And now in 1989, we figured that out. Those three figured that out. I had nothing to do with it. And of course, it made the cover of Science magazine. If I said Nature was the #1 science magazine, Science is 1A, I guess. So, and this little boy sitting down in front of what's supposed to be kind of a gene map there, showing that the gene has finally been discovered and the protein that causes CF has been discovered. Now, in 1989, and I was in fact doing CF care back then, we thought, this is the answer, we've got it. Gene therapy now, we've got a gene, we can fix it, we'll be all done, this disease is cured. Yeah, I see some smiling faces. That's not exactly how it worked out. We were a little naive at that time. So I'm not going to read through all of this, but basically around that time and over the next 10 or 15 years, we began to understand that there was a lot of genetic variation, that there was a lot of variation between one center and another in terms of taking care of CF. And so we started to work on a lot of those things. And I'm not going to read all of the slides, but I wanted to highlight that the foundation, CF Foundation, really got involved with recognizing the importance of patients and families as partners in healthcare. That if we don't get feedback from families, from patients, and Dr. Quinton being an example of a patient giving feedback, then we don't know what's going on. We need to help you and you need to help us. So it's got to be a team approach. So what's happened? This slide's actually a couple of years old. This says life expectancy 38.4 years. It's actually over 40 years now. And the slide at the bottom, it may be a little hard to read and to understand, but basically what it says is the average age, and this is again a couple of years old, was about 18 years. That means half the people in the country who have cystic fibrosis are adults. That was not the case not too long ago. This is because of great advances through science. And I'll try not to be too political, but we have to treat people who have CF, we have to have them have access, and we have to have funding for science. So that's as political as I'll get today. But all right, I'll get a little more political. With a little call your congressman, call your senators. And in fact, Maine has one of the bravest senators in the country who's willing to stand up to her party. So please encourage her that if you want, and again, there's lots of different issues to discuss, but if you want people with pre-existing conditions who didn't choose to be born with cystic fibrosis to be able to have access to health care, you might want to give your senators a call, but I'll end there. So over time, a bunch of things happened. So, well, I won't say over time, but certainly since 1989, we began to understand, you can kind of follow this chart from the top down, that what causes CF is a mutation in this gene that's known as CFTR. We don't have to get too technical about what that means. But that means that it makes less of the protein that you need in your cells to get the chloride in and out. Because remember, Dr. Quinton said it was a chloride problem. So we lose that chloride transport, and that leads to thickened secretions and plugging of the airways. And when you get plugging of the airways or plugging of the ducts in the pancreas, things don't work well. And that leads to what's called multi-system disease. And on this slide, we have a little cartoon of what that chloride channel is. Now, I grew up in a small farm town, and I've lived in small farm towns all my life. So I kind of think of this in terms of a pasture. Okay, you've got a gate in your fence, and you need to get the cows or horses or other livestock from one pasture to another. In this case, we're talking about the inside of the cell, which is kind of that bottom part, and we need to get the livestock, the chloride ions, out to the other side. And I really think the fence analogy kind of works, that if you've got a fence and that gate doesn't work, the animals can't get from one pasture to the other. If you've got a cell and that gate doesn't work, you can't get the chloride ions out. So this drawing here, kind of a cartoon picture, is showing normal functioning CFTR protein. That's the way it's supposed to work. In cystic fibrosis, that doesn't work, and we're going to talk a little bit more about what some of those are. And I hate to get too technical, and again, the science part that might put some of you to sleep, but this is important because the drugs that are coming out now are very specific to certain types of problems with that gate and with that fence, if you will, between the two pastures. So we need to kind of know what that problem is, what problem you or your child has or grandchild, so that we can then try to fix it. So again, I know it's a little technical, but stay with me here on some of this. I'm going to go back a little bit too. I think most of you know that people who carry a gene with cystic fibrosis are healthy. All parents of CF children are by definition carriers. This is what's called a recessive disease, so you have to have 2 copies of a bad gene, not just one. The point I want to make here is that the bad copy of the gene that comes from the mother or the father don't have to be identical. They can be different ones. So sometimes people have 2 copies of the same mutation in their gene, and the most common is something called delta F508 or F508 del. That's far and away the most common. But there's lots of others, like 2,000 other mutations. And one parent may contribute one mutation and one parent another, and they aren't necessarily going to be the same. So you need to know what your mutations are, what your child's mutations are, because that makes a difference for what medications may be helpful at this point. Now, we're hoping to get to a point where we can treat everybody all the time, but you need to make sure you know that and your family members know that. Does this even project?
Yep, that's good.
Okay. On my screen, it doesn't look very good. So just again, multi-system disease. Cystic fibrosis, we talk about the pancreas and the lungs all the time, but the sweat gland is involved, as again, Dr. Quinton pointed out. The liver can be involved, sometimes some scarring in the liver. The small intestines, lots of people with CF have problems with constipation and blockages because the linings of the large tubes get thick and sticky too. They just are harder to plug up than the little breathing tubes and the little pancreatic ducts. And male infertility is unfortunately a problem. The little tube that brings semen out, called the vas deferens, gets obliterated in CF2. So lots of other problems beyond just the pancreas and the lungs. This slide's way too busy, and I'm not going to go over in any detail, but this is to show you drugs that are developed in what the CF Foundation calls the drug pipeline, drug development pipeline. And again, first of all, you can't possibly read all that little printing, and I don't want to go through it bar by bar. But what I want to indicate is that there's a lot going on out there. There are a lot of drugs in development, some that have already reached patient care, but there's tons of drugs in development, and that's great for us. That means there's things on the horizon that maybe aren't available quite yet that are going to help our children and our adults with cystic fibrosis. So there's a lot going on, and we're going to talk about a few in particular as we go through the rest of this, but I just want you to know there's a lot out there. Way more than we can talk about in an hour or even 2 hours or 3 hours probably. So I'm going to get back again, just because we're going to have to talk about how some of these drugs work, I am going to get into the weeds a little bit of some science and what's going on in the cell. I'm going to use my fence analogy a little bit too, because again, I kind of think it makes it a little bit simpler, but there's several different types of mutations that can cause the disease cystic fibrosis. So again, to use that fence analogy, we're trying to make a protein, get that protein out to the cell membrane and have it work as a chloride channel. But to use the fence analogy, imagine the factory is shut down and it just doesn't make the fence. It doesn't make the gate run. You've got a fence, but you need a gate in it to let the cows, horses, whatever, from one pasture to another. If that factory just isn't even making gates, your fence is useless, or it's trapped everything on one side. And that's what the class 1 mutation would be. It's a mutation where you just don't make the protein at all. Class 2 is the gate gets made, but it's bent and funny, and the quality control people in the factory throw it out. In this picture, it's going over to that thing called the proteasome. That's the chloride channel protein gets misfolded. It doesn't fold properly. So again, think of a bent or crooked gate that no one's going to sell to you because it doesn't work. That gets thrown away. In this case, the CF protein gets misfolded. The cell's quality control mechanism figures out, hey, this isn't good, and it gets rid of it. That is the most common mutation in CF. That's that F508 del. Again, sometimes people call it delta F508. But it's that mutation that is far and away most common in CF, and that just is a protein that doesn't fold properly, doesn't work, and the quality control system of the cell says, get out of here. And it breaks it down and doesn't let it get to the fence to work as a gate. So it never makes it out to the cell membrane to open the way it's supposed to. Class 3 mutation, the gate gets there, but it's stuck. It's rusty. So you've got a fence, you've got a gate in it, but the gate won't open. You need a little WD-40 or 3-in-1 oil or something on it, but it's not working. That's not a very common type of mutation, but it's one that's of great interest, and I'll talk about that in a minute. In the class 4 mutation, the gate gets into the fence, it does open, but it doesn't open very far, so maybe a cow at a time can get through, but we can't get the whole herd through very well. So there's some function. And this is actually the mutation that Dr. Quinton has. He's got some function left in his chloride channel, but not enough. So people with this mutation tend to be a little less sick because they've got some chloride channel function. The gate opens a little bit, but it doesn't open enough. Questions on that? Does that all make some sense? Okay. So again, the delta F508 mutation is a class 2 mutation, and that's a real issue. And this G551D is the most common of the class 3 mutations. And again, that's an important one, and you don't obviously need to know the names of all of these, but that's an important one for our research and for the work that was done, particularly by Vertex Pharmaceuticals. And that R117H is the mutation that Dr. Quinton has. And again, he's very open about it, so I'm not spilling any information. So our first big breakthrough for therapy was this drug ivacaftor that Vertex, and we've got Vertex in the back here, that Vertex came up with. It was approved about 4 years ago, and this is one that helps that gate open. So it lets the chloride out of the cell. So this is for the class 3 mutation. So if the fence has a gate, but the gate won't open, this drug helps that gate open. So it's the WD-40 of cystic fibrosis, okay? And now it's been approved for ages 2 and above. So we can get in very early. And remember, Dr. Anderson in 1938 saw that infants already have lung disease. So the earlier we get in, and correct that problem, the better off we are. If we can get in there and correct the problem before there's an issue, that's great. And this drug works really well. So this was the study that was done that went to the FDA for approval. And I know a lot of you probably aren't used to looking at graphs the way Annie and I are, but basically the bottom line is people who were in a placebo group who did not get any real medicine, and over 48 weeks, a year, their breathing test, the FEV1, how much air they could blow out in 1 second, and that's a sign of airway obstruction, things blocking the tubes so you can't get the air out. Over a year, their breathing test dropped a little bit, which unfortunately is part of what happens with cystic fibrosis. We all know it's a bad disease that's slowly progressing. So the group that got placebo dropped their lung function over the course of a year by a percent or two, and that's unfortunately what we would expect. The group of patients who got this drug ivacaftor, that's now called Kalydeco, went up 10%. Instead of going down, they went up. And they sustained that up over the course of a year. That's amazing. That was absolutely, positively unheard of prior to this. We've tried things that treat drugs, that treat the symptoms, the infection and the mucus, but we've never done the basic defect like this. And we've never had this kind of result. So absolutely blown away. The problem is only about 4% of CF patients have that G551D mutation. So it's an amazing drug, but for a very tiny fraction of the population.
Can I ask a?
Yeah.
I'll try to ask this loudly. So 10% improvement, 10 percentage points, or 10% of the base?
This is absolute change. So this is 10%, a real 10%
10
point.
points of change.
Yeah.
And how much change would you need to kind of have normal flow? Would 20 be enough, or 30, or?
It depends where you start. It depends where you start. So this percentage of predicted, let me go back, because this is stuff that we talk about all the time, and I know you may not talk about all the time. And I'm going to step out and hopefully speak loudly. Can you all hear me if I speak loudly like this? So when we look at the breathing test, we know after not generations, but many, many years of doing these tests about what someone should be able to breathe out if they are healthy and don't have CF, don't have asthma, don't have any lung disease. And we call that predicted. We predict what you should be able to blow out. Then if you blow out exactly what we predict, that's 100% of predicted, okay? And no one, well, I wouldn't say no one, but it's rare to get exactly, but people are a little above and below, and we expect that. So anywhere from 80 to 120% of predicted is considered normal, okay? So this is a 10% change from what they were. Now, some of these people were probably about 50% or maybe even a little less. So they had advanced lung disease and were only half of what they should have been when they started, but they went up to 60%. Others may have been at 70 or 80%, and they went up to 90%. So they got closer to what would be considered normal. I'll put that in air quotes. But let me just say better, a lot better than they had been before they started this drug. And now that's been 4 years that this drug's been approved, and some of the people were in the research study for a year before that or more. We now have follow-up on people, and what we've seen is that there's a slower rate of decline. If you look at this bottom line of the placebo group, they lost function over time. And if you look at that over several years, you can see a decrease in lung function at a certain angle going down. What this drug has done is made that angle less steep, so less loss, if not staying exactly where they were, at least slower decline, which means many more years of life. If you start to project that out over 10, 20, 30 years, you're talking about much longer time until you need a lung transplant or you just unfortunately can't breathe anymore.
One more
Oh, yeah.
follow on the same idea, but does Kalydeco for this cohort produce the chloride flow that's normal? Or is it still somewhat diminished?
It's
that's my fundamental.
It's still somewhat diminished. The flow. So the question was, is the chloride flow completely normal? And a slide I didn't show here because I didn't want to overdo too much was they actually looked at sweat chloride. So remember, the sweat gland is what Dr. Quinton looked at, and the chloride going in and out. People with CF don't reabsorb chloride well, so they've got more salt out on their skin. And normally the number is 100. We consider less than 30, less than 40, it's a movable number, but say less than 30 is completely normal, less than 40 is probably pretty normal. People drop from 100 to 50. So almost to normal. almost to normal. Certainly into what we would call kind of the maybe range, because over 60 is considered diagnostic of CF. These people were mostly around 100. They dropped down below the diagnostic level. So yes, it affects chloride channels tremendously. And we believe that that then increases the water in the airway, decreases the mucus thickness in the airway, and that's why the breathing test gets better, because you can clear out your airways better. Great question. Other questions? Okay, I know, and again, I know some of this gets a little detailed. So the next drug, and you know, Vertex has done a great job with this. The next thing they did is to look at a combination of something they called lumacaftor and ivacaftor. I know these names get a little complex. It's now sold as the drug Orkambi. And this is working on the most frequent mutation problem, that class 2 mutation. So it works on that delta F508 to help it fold properly. So if you will, the quality control people are bending that gate back into a normal shape so they can then put it in the fence and get the pigs and horses and cows to go from one pasture to the other. Okay? So they're straightening out the fence. That's the point here. And then the ivacaftor helps to keep that gate open. So the combination of correcting the folding mistake and opening the gate is going to be helpful for people with 2 copies of the F508del mutation. Again, this is getting back to why you need to know what your mutations are, because these are mutation-specific therapies. That was approved in 2015. It's now available for ages 6 and above. There are trials going on for safety in 2 to 5-year-olds too. So again, getting in early before there's established lung disease.
Quick question?
Yeah.
So if a person or a child, a patient has one 508 mutation, it has no effect. You need to have 2 copies of that.
Yeah, so the question is, you have to have 2 copies of F508 for this drug to work well. And I'm actually going to show a little bit more about that. But the answer is yes, for the most part. There's some variability on that, but for the most part, yes. And that's one of the issues, because that doesn't cover everybody. And the G551D adds a little bit more, but that doesn't cover everybody. So we're definitely, in October 2016, the North American CF Conference had a big talk about how we need to get to everybody, and I actually stole a couple of their slides too that I'll show you in a minute. But yeah, we're not there for everybody yet. We're not there for everybody yet. The problem with lumacaftor, ivacaftor, or Orkambi is that this slide is just showing that in the Kalydeco went up 10%, this is only going up 3%, 4% at the most. So it's not nearly as big a change as we saw with Kalydeco. What that means is lumacaftor is a great idea. It helps to fold the protein, but it's not good enough. And I'm a little embarrassed to say that in front of the Vertex people, but my apologies. But we'll get to the next step too, okay? It's a good proof of concept. This is proof that we can help that protein fold, get the gate into the fence properly. But boy, we'd like to have quality control be better about fixing that gate and getting it better. So yes, it can work. And some of the patients we've seen who have been put on this have had really big improvements. You know, 4% is an average. Some people have a bigger improvement, some a less big improvement, or even perhaps no improvement at all. So this is an average, but there certainly are some people who've responded nicely to this. But it's not the home run we were hoping it would be. So yeah, I wanted to mention that the conference in October of 2016. Every year there's a North American CF conference. It's misnamed because it's really an international conference. And this past year we had about 4,600 people from over 40 countries there. It's all kinds of, this is a CF team. This is a team sport. And you guys all know that. There's nutritionists, dietitians, GI doctors, lung doctors, social workers, nurses, there's respiratory therapists, everybody. It's a team concept. And people from all those disciplines are at this meeting. It's scheduled as a 3-day conference, but really it's a 4th day. There's a day before for bigger learning sessions, especially for people who are kind of new to cystic fibrosis to get them up to speed. So it's a big deal conference. And each day, there's one very large breakout, like this. A group of this, only it's with 4,600 people in the audience instead of 75 people in the audience. It's a big deal. And I just want to show that in this first plenary, the real theme was a cure for all. This gets to your question, sir, about who can get treated. Right now, lumacaftor and ivacaftor, roughly half the patients have 2 copies of the delta F508, at least in the United States. So lumacaftor, ivacaftor, Kalydeco is good for roughly half the patients, a little less. Ivacaftor alone is good for the G551D, but it turns out there's some other of that class 3 gating where the gate doesn't open quite well, and the ivacaftor helps that. And that mutation that Dr. Quinton has that works a little bit, again, if you think of ivacaftor as the WD-40, it helps that gate open even a little bit more. So when we look at all of that, we're getting over 50% of people with CF having a drug available for them now. And that's great. That was not the case 4 or 5 years ago. Okay, so we can be negative and say, oh, it's only half the patients, but that's 50% more than we had before. So that's pretty exciting. What we want to do is to see if ivacaftor can be approved for even more mutations. And in fact, Vertex has been working on that and working with the FDA. And this slide is a year old now, we're almost a year old, so there have been some changes. But we want to see if we can get a drug that can help people have 1 copy. You know, there's another third, that 36% who have 1 copy of delta F508. And then there's another 5% or so, 5 to 10%, who have no delta F508 and have really difficult other mutations to treat. And they're kind of right now, unfortunately, the hardest group for us to even think about treating. We don't have treatment for the single 508 group yet, but certainly companies are working on that. So we want drugs that are going to work even better than Orkambi, and maybe help other organs than just the lungs, although the lungs are obviously our major target. And we need to treat all patients, and we need to look at all the mutations, not just the F508 and G551D. And as I said earlier, and Dr. Anderson pointed out, this disease starts early in life. So we really want to start treating young patients, and maybe even patients who have no symptoms at all. Kids who are picked up with newborn screening who are completely asymptomatic. But if we can start treating their chloride channels before they get sick, maybe there's nothing wrong with them at that point, which would be kind of cool. And I gave this talk actually several years ago, and it was at UMass, and one of the people, is Peter Newberger, just said, well, maybe we should treat the pregnant women, so we treat them in utero. And, maybe we should. We know that a certain percentage of kids, actually a lot of them, are born with pancreatic problems already. So in fact, we probably should be treating in utero to prevent the pancreatic disease and the loss of the vas deferens in males prior to delivery. So it may be that the mothers need to be treated. So again, another reason to find out what your carrier status is. So the CF Foundation, how do we get from knowing about the chloride channel in 1983, knowing about the gene in 1989, to actually developing drugs? And the CF Foundation has worked really hard to help us help you. And one of the things they developed was this thing called the Therapeutic Development Network. And essentially that's a team of centers working together to do clinical trials. It was developed in 1998, and actually they took a little heat at the time because they only had 7 centers in it initially, and a lot of us who weren't in those 7 and said, hey, we want to take part too. And the foundation has really listened to that and paid attention and grown. And now 82 sites across the country take part in TDN trials, and Maine is one of them, correct? I want to make sure, yeah. So this is where the rubber meets the road. This is where we take a drug that's been used, been looked at in the laboratory and in cells from people who have cystic fibrosis, and we see, yes, it works in a petri dish, but it doesn't work in human beings. And clinical trials are where that happens. Now, the Therapeutic Development Network also has what are called protocol review committees that look at, so companies come to we call it the TDN. Companies come to the TDN and say, gee, we'd like to do a trial in CF. And the TDN then has review committees that look at the safety, the potential effect of the drug, and where does that stand in our pipeline? What's important? Where do we have to go from here? So what's its priority? And then with those scores, safety, effectiveness, priority, the clinical trials go forward if they kind of meet all 3 of those criteria. So right now, this is what's happened. The TDN activity has gone up tremendously over the last several years. You can see the yellow is ongoing studies and the blue is startup studies. So each year, we're doing more and more clinical trials. What's that mean? It means each year there's more and more drugs potentially available for people with cystic fibrosis. And that's wonderful. We do have a problem though, and that is this slide shows people being in the research trials, and the blue hash marker dotted area is how many people we thought would be in clinical trials, and the yellow is, or yellow-greenish, greenish I guess it is how many actually were in the trials. And what you can see is that we don't have as many people in clinical trials as we hoped to have in the clinical trials. So we need people being people with cystic fibrosis, to volunteer to be in clinical trials, because without that, no subjects, no data, no answers, no new drugs. So this is my plea to you guys, both looking on the computer and here in the audience, to think seriously about enrolling in clinical trials or having your children enroll in clinical trials, because without that information, we don't move forward. We don't get Kalydeco or Orkambi, whatever else is next down the line, if we can't test them. And someone else tested other drugs to get where we are now. So you're paying it forward, if you will. So some new results. So I've talked about where we are, but where are we going? Well, very recently, Vertex announced that their new drug, it's a corrector, it's kind of like lumacaftor, and they call it tezacaftor. And I'll talk to you guys later about where you come up with these names. But the combination of tezacaftor and ivacaftor, so that's, again, something to correct the folding so the gate is made properly, and then something to keep the gate open when it gets into the fence. That combination was tried in people with 2 copies of the F508del mutation, and it had results pretty similar to lumacaftor, maybe a tiny bit better, but not a lot better. But the real benefit is that it has fewer side effects. So a lot of people who started on Orkambi felt some initial chest tightness and some difficulty breathing, maybe some asthma-like symptoms, and a number of people haven't been able to continue on Orkambi because of that. This drug has fewer of those problems, and Orkambi is a really nice drug, but it's got interactions with other medications, and people with CF, you may have noticed, are on more than one medication. A lot of different medicines you're taking or your kids are taking, and there's this thing we call drug-drug interaction, where these drugs interact with each other and can cause problems. This tezacaftor has fewer of the drug-drug interactions. I think Vertex is thinking, and they've been very public about this, that this is, they hope to be the backbone of perhaps a 3-drug combination where we use another corrector, something else that helps the gate get made properly, along with tezacaftor, along with ivacaftor, in a 3-drug cocktail, if you will, for treating CF. And that's probably where we're headed, although obviously there's a ways to go between a theory and actually having a drug approved by the FDA. But the hope is that triple combination would then provide much more than that 10-12% increase that we saw with Kalydeco. There's more going, oh yes?
Would that 3-drug combination have an effect on other organs besides the lungs?
Yeah, so certainly that would be the hope, that it would help the sinus disease. If your pancreas is already scarred and kind of gone because of a life of cystic fibrosis, it's not going, those drugs aren't going to make the pancreas regrow and come back. So people on these drugs, and thank you for asking because I really didn't talk about that at all, these are very good, what we hope will be very good for lung disease. They're not going to make the pancreas better. So people with CF are going to stay on their pancreatic enzymes if they're already on them, because we're not going to get that back. What we may do, though, is save enough of the pancreas that CF-related diabetes becomes less of a problem, potentially. If you can save some of the pancreas, you make more insulin, you don't get into the diabetes problem, perhaps.
To carry on to your question, if you started, though, at age 2, would it preserve your pancreas possibly?
So if you can start it early enough in life, maybe you wouldn't have so much pancreatic disease. One of the studies actually that we did, it was a multi-center trial, but we started at UMass, was looking at pancreatic function throughout the first year of life and at monthly checkpoints. And what we saw was there was a lot of up and down. There seemed to be pancreatic function that was able to be rescued. You know, it would come and go a little bit, and if you intervened early, you could prevent, we think, total loss of pancreatic function. Probably it has to be in the first year and a half of life. So we're not there yet, but yes, that's certainly a possibility. sinus disease, the sinuses are lined with tissue that's very much like in the lungs, so we would hope that something that was good for the lungs would be good for the sinuses too. And again, this gets back to starting the medicines early, but if you already have advanced lung disease and you've got pockets of your lung that have been destroyed because of cystic fibrosis, that's not going to get all better. So people who get these drugs are still going to need other medications for now. 20, 30, 40 years ago when we started, from now, not ago, 20, 30 years from now, when we started babies on these drugs, we may not have that kind of disease that we have to keep taking care of.
Dr. Sullivan, thank you. Would you want to sort of reflect on any observations that we already know on Kalydeco and what can be their impact on nutrition?
Sure.
They've been studied, yeah.
Yeah, I'd be glad to, but I don't want to make plugs for companies, okay?
No,
So I'm a little careful about that. Nutrition is a big issue, and the pancreas is an issue. It turns out that, in fact, Kalydeco in particular has definitely shown positive weight gain. Now, that I'm guessing that has to do with the intestine more than the pancreas. The people who are on Kalydeco are still taking pancreatic enzymes, but they seem to absorb calories better, and it probably has to do with better intestinal function, and perhaps some improved pancreatic function too. I think that's hard to get at for sure. Yes?
Most of the drugs that you've shown here, they don't take till the age of 2 or 6.
Yeah.
So what drug would help preserve the function within the first year of life?
Great. So the question is, the drugs I'm showing that affect the basic defect aren't approved for infants. So what do we do for infants? Everything we've been doing for the last 20 years. Chest physical therapy, antibiotics for people who need it. Nutrition is huge. Nutrition is huge. There's a strong correlation between poor growth, poor body growth in the first years of life and poorer lung function when you're 6, 7, 8 years old. So we need to keep children well nourished. We need to do the chest physical therapy on them. We need to give them medications that help to break up the mucus. And you're right, I haven't talked about things like pulmozyme and hypertonic saline, antibiotics, and I am actually going to mention them briefly, but those are the traditional things. And the key is to keep up with all the traditional things until medications that treat the basic defect are available to everybody. So for that 50% that we're not treating right now with these drugs, again, the key is keeping up with what we know has been beneficial for the last 20 years. Because the healthier you are when the new drugs come out, the better off you're going to be. If you've lost a lot of lung function already, you're not likely to get a lot of that back. You may get some of it back, but you're not going to get all of it back. But if you can stay at 90% of predicted, and the new drugs come out, maybe you stay at 90% of predicted the rest of your life. But if you let yourself slip down to 30% of predicted, maybe we get a little back, but you're still going to have lung problems. So the key is really good, close, careful attention to the care that Dr. Coates and everyone else at Maine Medical Center is giving to you now. That's the key. And I think in my own practice, I never thought, oh, well, it doesn't matter if you take your medicines or not, but I'm even more talking to people about, you've got to stay on your medicines now because we're a few years away from having treatment for everyone that may be absolutely positively paradigm shifting, life changing, that we're going to make huge differences. But if you've messed up and not taking your medicines now, it's hard sometimes to tell a 15-year-old or a 16-year-old about that. It's adolescence, unfortunately, and it's a problem. But if you stay healthy now, you're going to be healthier longer because there are going to be new drugs out. Okay, I just have a couple more slides. I don't want to bore you for too long, but again, some new stuff out. So I do want to get to the fact that not everything has to be treating the basic defect. That's kind of our goal, the holy grail, to treat the basic defect. But in the meantime, right, what else are we going to do? So it turns out there's this drug, enobasum, I'm not even sure quite how to pronounce it, that's just been through phase 2 trials. Phase 1 is making sure a drug is safe. Phase 2, safe in the population with the disease and that it's got some effect. And then phase 3 are the big trials that go for FDA approval. So this is still a ways away from that. But it's an anti-inflammatory. Part of the problem with CF lung disease is there's inflammation in the lung, and inflammation chews up the lung tissue. Your own body's fighting infection, and that fighting ends up hurting lung tissue. This dials back that inflammation, so there's not so much irritation in the lung, there's not so much chewing up of the lung tissue. And that looks pretty impressive. And there's another company out of Europe called Galapagos that has another corrector that would be on the same idea as the lumacaftor and tezacaftor, working somewhat differently. And they're moving forward, and that's good to know. And then there was a drug for the last 5–10% who have the, getting back to our gate analogy, the factory just isn't making the gates at all. This is for people who don't make any of the protein at all. It's called adalurin, and unfortunately it failed in a phase 3 trial. So it's kind of back to the drawing board for that population, unfortunately. I'm actually going to skip through this slide because it's a little complicated. There's no real reason for it. This is cool. It's a cool science. And I realized this was, again, slides I stole from the CF Foundation. There's a new thing out there called CRISPR that some of you may have read about in the newspaper, where you actually can do some gene editing. And the slide they showed was, if you've got a rip in your jeans, you want to cut out the bad fabric and sew it up with new fabric. I realized most of you probably have ripped jeans that you paid extra money for. So, I'm not sure this analogy works. You're trying to put more holes in your jeans, not fewer holes in your jeans. But the idea being that if you can take out the damaged part and put in a healthy part, you can fix the problem. That would be amazing. And that actually is doable in the test tube now. There are people who are doing that in the test tube, in petri dishes, in laboratories. And the idea is this CRISPR-Cas9 is a protein that kind of chomps along, and it chomps, you can program it to chomp out a specific piece of DNA. And then you can put back in the code that you wanted to have there, to make an amino acid that you want to be the right one. So you can chomp out the mutation and put in normal genes. Sew it back up, if you will. I'll be honest, I don't know how they do this, okay? This is a pay grade above mine. I don't get this. But it works. It works, and it's pretty amazing. It's actually opened a lot of ethical dilemmas, too, because what if you say, I don't like brown eyes, let's clip out the brown eye gene and put in blue eyes, or gee, I want to not be short, I want to be tall. So there's a lot of ethical issues that we really have to think about seriously. Annie mentioned that I have an interest in ethics too. That I think this is not a simple slam dunk, except for when your child has CF, it's a pretty simple slam dunk. Let's take out that bad gene and put in a good gene. I'm not sure how this is going to work in humans right away. Again, in 1989, we thought gene therapy was going to be easy, and it was not. Fooling Mother Nature is difficult, and Mother Nature doesn't always like to be fooled, so we have to be a little careful about what we're doing. But this offers great promise. The idea to be able to clip out the defect and put in a normal sequence of base pairs, which is what DNA is made up of, and to be able to do that would be pretty awesome. And it's moving forward. We have to be a little careful about it, but it absolutely is moving forward. Again, just all these different things that are going on. I don't want to go through all of this. Back to the fact that we've got more going on than just lung disease, because I want to talk about a few of the other things that the TDN is working on, the CF Foundation is working on. New ways to try to clear mucus out. Again, this gets to what do we do before we have basic therapies for all the different genetic mutations. Well, we want to make sure we clear out the airways. And so there are a couple of drugs, including another one from Vertex called VX371, that helps to move water out of the tissue and into the airway to make the lungs wetter so the mucus is less sticky, so you can get it out better. Better ways to treat infection. We have lots of antibiotics and we've used lots of antibiotics, but we want to make sure that we have even more and better available. So there are more of those, and this STOP2 trial is one that's enrolling patients now that's looking at how long should we treat with IV antibiotics. Certainly those of you who have had children who are sick or have been sick yourselves know that you often spend 2 weeks in the hospital. Well, that number of 14 days of IV therapy is kind of made up, to be honest. We don't know exactly what the right amount of time that someone should be getting IV therapy is. So this STOP2 trial is trying to look, is there a shorter or longer time that's better for CF, what we call exacerbations, when you get a flare of your CF lung disease. So that's a trial that's enrolling patients now that may be very helpful to let us know how to take care of kids and adults until better therapies are available. There was mention of nutrition and GI. and I don't want to underestimate the importance of this. I am a lung doctor. I tend to talk about the lungs a lot, but in fact, nutrition is incredibly important, and we know lung growth occurs after birth, and lung development occurs after birth. And if you don't have good nutrition, your lungs aren't going to develop normally, no matter who you are, no matter what disease you have. So nutrition is key to keeping lungs healthy, and there's a close correlation between good nutrition early in life and lung growth afterwards, and lung health afterwards. So people are looking at new vitamins, looking at new enzymes, including some liquid enzymes, so you don't have to give little beads to babies, which would be a real bonus. And this Alcresta inline device is called Relazorb. Have you guys been using Relazorb at all? We've been really happy with it. This is a little cartridge that goes in line for people who are getting tube feedings through gastrostomy tubes, and it helps to pre-digest the formula that goes from the bag before it reaches the stomach. It's this little cartridge that goes in line. It's been really very cool and very helpful. So people absorb food better overnight when they're getting tube feedings. They don't have to wake up in the middle of the night to detect pancreatic enzymes the way they might have. Not that very many really did, but they probably should have. So this takes the place of that. And worldwide efforts, we've just got a couple minutes left, but this CF is not just a US disease, it's a worldwide disease. And so there are 30 countries worldwide taking part in international studies, lots of different CF mutations, so that we can now look at different mutations in different areas and get an idea of which therapies might be best for which mutations. Let's go this very quickly. There's just studies in different countries. Again, I don't want to spend a lot of time on this, but just to let you know that US is not alone doing all of this. But again, and I've said it before and I'll say it again, if we don't get research subjects, whether it's in the United States or in Europe or Australia or New Zealand, we're never going to know what really works. Again, I'm going to skip through some of this because it does just kind of reiterate some of what I said. So I'm going to close with just, again, life expectancy over the last 80 years. That's a pretty nice curve. But it stops at 42 right now. And believe me, there are people older, Dr. Quinton's 72, this is averages sorts of things. So it's not to say any one person is going to be well until 41 in 11 months and then drop off at 42. So these are averages. That's a pretty nice curve. We want to see it go even higher and better. 1980 is when I graduated from medical school. The average life expectancy then was about 20 years. I rarely saw an adult with cystic fibrosis. Rarely saw an adult with cystic fibrosis. Now, half the patients in the country are over 19, 20. So it's changed dramatically. And you can see how sharply the line's gone up since I graduated from medical school. I take full credit for that. I graduated from medical school, CF got better. There, I think that's obvious, right? Yeah. Correlation isn't always causation. It happened, but it's not, I don't think I can take credit for that. Just to show you some of the other things, again, I was talking about the newer things. 1993, Pulmozyme was approved. That's the medicine you inhale that helps to break up the mucus. 1998, I think it was, tobramycin, inhaled tobramycin to treat infections. 2003 is zithromycin, which is an antibiotic that also has anti-inflammatory properties. Remember I said a minute ago that inflammation, too much inflammation can be a problem in CF lungs. 2010, Caistin, another inhaled antibiotic to help fight infection. 2013, Kalydeco, which I made an even larger arrow because that was such a big deal. And then 2015, Orkambi. What we need, and I don't have an arrow up there for, is the next one that leads us to complete resolution. The little boy who was sitting in that picture on Science in 1989, he's all grown up. Those medications I just pointed out to you on that graph, make a difference. And again, getting back to your question earlier, what do we do until we have these out? We use the medications that are available. They make a difference. Danny has grown up. He's been at some of the North American CF meetings. He's talked at the, it's a pretty impressive story. And then I'm going to close with this slide that called Cystic Fibrosis. This is an article that was printed in 1974. And the title was Cystic Fibrosis, a Not So Fatal Disease. Well, in 1974, I think it still was a pretty bad disease. I think in 2017, I'm sorry, I'm losing track of where I am. In 2017, we really can start to call this a not so fatal disease. And hopefully, a very treatable disease going forward. So I've taken my full hour. I wasn't even sure I could do that, but I'm happy to answer any questions. And if you have other breakouts, I'll hang around for a while if people want to talk separately too. So thank you.